Hi, my name is Stephanie Hedgecock. I'm a licensed professional counselor in private practice, and Dr. Beery asked me if I'd give a brief informal talk for her students who'd be future clinicians, educators, and parents about what I'd want them to understand about ADHD. And so I invited Andy in to help me by asking me some questions as I go along, and also maybe to break up the monotony of just hearing my voice for however long it takes me to go through this with you. So I think what I'll do is, since it's such a huge topic, and obviously there's no way to do it justice in a brief talk. I know Dr. Beery's, intention is that I just kind of give a brief overview, and then you guys can take it and go further with it depending on your level of interest. But ADHD is the most prevalent childhood disorder. It's a complex neurobiological disorder, and it is a developmental delay. You know, kids who have this are developmentally delayed. And on average, that delay is about 30%. And that statistic has been given by Dr. Russell Barkley, who's a world-renowned expert in the field of ADHD. He spent 35 or 40 years leading research, doing clinical studies, being a clinician, actually working with individuals and families, and doing lectures and talks for both clinicians and the general population for many, many years. He retired a year or two ago now, and he took all those lectures and talks and he put them on YouTube for free, which is a phenomenal resource for all of us who are in the field, or if you're a parent who has a child with ADHD or an educator, because I think you can learn so much from just listening to him for an hour or two. He has one video in particular that I recommend to every family that I work with, and it's called Essential Ideas for Parents. It's just under 3 hours. I think it's 2 hours and 51 minutes, which sounds like a long video, but he's such an excellent speaker, and there isn't a single point that he makes that doesn't really captivate your attention, because it's all very important. I think he breaks it down into 30 essential ideas, and he talks on each one of those, and it's incredibly helpful. So when parents watch that, they learn more in that 3 hours, they tell me, than they did in the 3 or 4 years prior to that, trying to read books and go to different, experts in town and learn from them. So what I have found is a lot of times people that come to me for therapy for their child or their family, they've been trying to kind of muddle through on their own for a year or two, sometimes longer, sadly, trying to pick up information from books or from people in their life. And there is a lot of misinformation and myths out there about ADHD. So I think it's really important, if you have a student or a client or a child of your own, a family member who has this disorder, or you have any concern that this child might have ADHD, get them into somebody who specializes, who has the knowledge, the expertise about this disorder. Get them tested right away, get an educational psych eval early on, so you know exactly what's going on and you have some good recommendations that you can work on over time. Early intervention is critical. Having the right diagnosis is critical. And plugging into some specialists, some experts that can help you start to navigate life with this disorder will be immensely helpful. And the alternative to that is usually just a lot of stress, tension, irritability, and anger in the home, alienated parent-child relationships, high conflict sibling relationships, ADHD kids who have no friends, or maybe one friend or two if they're lucky. And we'll get into why that all happens, but the point I want to make now is watch that video if you plan to work with kiddos or you have a kid who has ADHD. Plug into an expert in the field of ADHD if you have a child, a client, or a student who has ADHD. If you're not that clinician that wants to specialize in this or do the advanced training, that's okay. But make sure you know one or two in your community who does, so you have somebody you can refer to. This isn't the kind of disorder that lends itself to more generalized tools that we may use for other disorders or disabilities when we talk about children with disorders, okay? So you do want to plug into somebody with some expertise. And I think I'm going to turn it over to Andy to ask me, and we haven't discussed this, so you're. I thought it would be better to just be authentic and in the moment. We've both raised a child with ADHD. Jack, my 18-year-old son, has ADHD, and Andy and I met, or actually began dating seriously when Jack was 4 and got married when he was 6 years old. So Andy's been along for the long haul with all of the learning we've had to do personally with ADHD. So what do you think? Hit me with a question that you think parents might need to know.
So probably the most important question I think other parents would want to know is school. Mm-hmm. So when your child is diagnosed, when you have an inkling that they have this condition, what do they need to know in terms of the interactions with the child at the school and then with the parent in the school? What additional...
What do parents need to do at school?
In terms of relationships and communications.
Okay. Yeah, that's a great question. And, obviously you know that from experience that it's important. The school environment is where kids from 5 years old until 18, and if they go on to college even longer, spend a huge percentage of their time. Their waking hours are spent mostly at school most days of the week. So you want that environment to be an environment they can succeed in. You want them to be able to be not just academically successful, but socially successful. And that's going to take something very different from the other kids in the class. The complex neurobiological disorder that I mentioned previously, it's brain-based, right? Neurobiological. It's based in things that are misfiring in the brain. Some people would say this brain isn't quite online yet, and that's when we talk about the delay. But more specifically, there are regions in the brain that are visible on a SPECT or a CT scan, visibly different than the non-ADHD brain. So knowing that these things are outside the control of the child, and these things being, this child is going to be usually more talkative, more restless, more fidgety. They're going to have difficulty with attention, and not the same kind of difficulty a child with, say, anxiety or depression has with paying attention. This child's difficulty with paying attention will be more with working memory. They're not able to hold on to what they were doing as well as the other kids in the class. So if you're teaching this child math and they're expected to hold on to some of the beginning stages of the equation or the arithmetic that other kids just have memorized and in their working memory, this child is not going to be able to hold on to that as well. So you have to externalize it. So if I'm a parent and I'm working with a teacher and my child has ADHD, I'm not only going to need to talk to them about, my kid's limited working memory, how do we externalize things that other kids hold in their mind? Do we need marbles or some kind of manipulatives for math? Do we need Post-it notes on their desk or some kind of list around the room so they can remember what the steps in the project were or the task? But also I'm going to have to help them with the social part of school, because a lot of what's going wrong with ADHD is the emotional dysregulation, and that's going to make this child much more likely to blurt out inappropriate things, to interrupt their classmates when a classmate's trying to present something or answer a question. It's going to make them much more likely to steer the teaching off task and to start telling some random story that they thought of while the teacher's trying to present something. It's going to make them more likely to put their hands on other kids, to get in the personal bubble of other kids. And when they get angry, when they feel like they've been left out or treated poorly, right. This is a child who's going to be very reactive. And because, they think it, they say it. They don't have that stop and think filter, So whereas other kids might feel just as irritated or frustrated about something, this is a child who's far less likely or able to subdue that reaction, think about it first, and decide, is this in my best interest to hit this kid who just, did something I didn't like, or to call him a name, or to blurt something out, or to yell. This child with ADHD is going to have a much more difficult time socially at school. So the teacher is going to need to understand the parent needs that collaboration. Parents want to know, how is he doing at recess? How is he doing at seat work? How is he doing? And it's not the normal level of, feedback. You're looking for, does he have any friends? Is he alienating himself from other students? What are some ideas we can talk about and some strategies we can use to help with that? This child will need more, performance-based supports, external things that other kids have internally. Interventions, one that I know was important with Jack when he was in grade school, and really through middle school, at least through 6th and 7th grade, when he would be turned around talking to other kids. The teacher's up here trying to teach a lesson, wanting everybody to be listening, and I would hear he would have his back turned, sometimes talking to his neighbor. And they might actively ignore that and reinforce the good behavior of other kids in the class. Well, that doesn't work for ADHD. For a child who's really wanting, paying attention and able to perform, it's not whether they want to. They want to. If he were able to get his brain to be aware of what he's doing and then turn his body around, he would have. So we had to use the strategy of getting very close to him, especially in grade school. Eye contact. Jack, your back is turned around. Your back is facing me. I need to see your eyes. Please turn around and listen while I talk. So giving clear, this is what you're doing that I don't like, this is what I need you to do, and expecting that. And giving him that cue and then reinforcing it, because internal motivation and drive isn't working right for kids with ADHD either. So what happens is you have to sprinkle on those external motivators in the environment where you want the child to perform. For a neurotypical kid, just giving the feedback and knowing, I'm pleasing my teacher, I'm getting the good grade, I can think ahead and know how that's going to, reward me down the road. But with ADHD, none of those things is firing properly. The internal motivation and drive is broken, the ability to think down the road and identify that what I'm doing right now in this moment is going to make an impact a month from now, a year from now, the end of the semester. Those things are not, this child is not capable of those things. So you have to do a lot in the environment. So I would say, meet with the teacher early. Let the teacher know the diagnosis. Share the educational psyche eval results. Here are some recommendations. Collaborate with the teacher. Show the teacher the utmost respect. Obviously, they're the expert at teaching. You're just the expert at your kid. And we really want to have a positive relationship with any educator in your child's life. So communication, asking how the teacher likes to be communicated with, asking how often is enough.
Frequency.
Yeah, frequency, good point. And then also making sure that when you make a change at home, whether that's, a medication change or some kind of family system change, that you drop a note to the teacher so she's aware to keep an eye on your child, okay? So does that answer everything? Okay.
So a good follow-on to that, you talk about changes at home. So you're working to collaborate with the school, with teachers in your child's life, and then anybody else, principals, assistant principals. At home, when you're working to direct behavior or motivate certain behavior and mitigate certain behavior, you already talked about the eyeballs, that contact. I've learned that lesson, not having eyeballs, walking through the room and issuing a command does not work. All right. What are things to avoid and then things to reinforce for parents at home?
Okay. So first, we probably need to understand what's going wrong. You know, if you don't have a child with ADHD, you might be thinking, well, why would you handle this any differently than any other child who's, you know, in need of some kind of intervention or correction or discipline? And so when we look at ADHD and what's going wrong, I've touched on it briefly, but I think what we need to appreciate is that the neurology here, what's going wrong, both in development and when you look at what's going wrong in the brain, when you look at the structure of the brain, certain structures of the brain are smaller for the ADHD person when we've looked at that. Now, some of that catches up. By around 18, we see that some of those smaller brain structures do grow. They just grow at a delayed rate. And then we look at the neurotransmitters that are low, the dopamine, the norepinephrine, the epinephrine. And the medications help with that a lot. You know, we used to talk about, you know, doing everything we can do first before we resort to medication, as if that was a bad thing to do. But now when we look at it being a neurogenetic disorder, we want to use pharmaceuticals that are neurogenetic treatments for this disorder, and the stimulants and even the non-stimulant Strattera. These medications have been around since the 50s. The newer one came in 1976, I believe, but you know, the amphetamines and methylphenidate are the two classes of medication for ADHD. And we've done a lot in the recent, I guess, decade or so with delivery mechanisms, you know, Vyvanse, Concerta. We've done things to try to allow the medication to last longer, to be delivered in either scheduled bursts throughout the day or slowly throughout the day. There's a Daytrana patch. There's medications to try to better meet the needs of kids so they don't need to go to the nurse in the middle of the school day and get a med. But that all being said, unmedicated, you've got a child who is, you know, more emotionally raw, more emotionally intense. This is a child who will have a very difficult time with transitions. So when you say, you know, Johnny, it's time for dinner, go wash your hands. Even a neurotypical child who's in the middle of doing something fun might be tough to convince to get moving, but we can do it. We can, you know, give them a warning like, hey, 5 more minutes and we need to get up and wash our hands, it's time for dinner. And we can issue an incentive or a punisher if you don't do that. But with the ADHD child, that transition is far more complicated. They aren't as able to stop what they're doing and then shift, especially if they're going to shift to do something less rewarding or fun. And that's going to be homework, a chore, washing up for dinner, getting ready for bed, whatever the case may be. Those are all things that they're not naturally going to be excited about doing. So you're going to have usually a bit of a battle on your hands with a child who has ADHD. So we want to structure the environment to make that as positive and successful as we can. And we do that through behavior modification program. The one I would recommend for any new clinician or parent or teacher is the book from the book Taking Charge of ADHD by Dr. Russell Barkley. It has an 8-step behavior modification program in the book. It's simple to follow. It really does work. It's a program that I've taught in little mini workshops and seminars. It's a workshop that I take parents through when they have a child with ADHD. And I think it's something that if you wanted to consult more about it, feel free to contact me. I'd be happy to work with you on how to decipher or interpret those 8 steps, but it's pretty simple. And I would definitely utilize that or something like it in your home. You're gonna have a house with more charts and lists. You're gonna have, for small children, probably up till the age of 12, maybe 13, depending on your child, on the refrigerator or, you know, on a wall in the kitchen or somewhere, you're going to have a list of responsibilities. You know, these are the things you need to do in the morning, and it can't just be a list of things you need to do. It needs to be, you know, wake up by, and you put the time, 7 a.m. And yes or no, did you do that? Brush your teeth by 7:35 a.m. Yes or no? Make your bed by 7:38 a.m. I've been saying p.m. I meant a.m. Anyway, every task that you have for the morning, wake up, brush your teeth, make your bed, eat your breakfast, and label it. You get 10 minutes to eat breakfast. From 7:38 to 7:48 a.m. we eat breakfast. From 7:48 to 7:49 a.m. put dishes in the dishwasher. So every task is written out with a time allotted to it, and yes or no, you did that thing. And with your parent, parent-child, before you go take off for the school bus or get in the car, you get a sticker for each one of those things you did complete, or a smiley face if you don't have stickers. You can draw it on there, or you can put a check, no, or a smiley face, yes, an X, no. And so at the end of the morning, say you had 7 tasks you needed to complete. If you got 6 out of 7 of those finished on time without prompting, without more than one prompt from mom and dad, you earn 6 points. And those points add up. And you, at the end of the school day, as long as you had an incident-free day at school, which means you need feedback from school. When you talked earlier about collaborating with school, I always recommend having some kind of behavior plan at school as well, and it needs to be discreet and respect the child, and it needs to be something the child feels good about, that this is helpful for him or her. I love just having a sheet there on the student's desk underneath their work or somewhere in or on the desk, and each segment of the day is blocked, seat work from 8:55 a.m. to 9:15 or 9:20. Did the child do what he or she was supposed to do? Yes or no? If there's a comment, like something happened and you need to make a note of that, you jot it in the little note box. You get a sticker if they did it, or a smile face, or whatever, a plus mark. And for each block of time you do that, and at the end of the day, if the child had no major incidents and they did 80% or better of getting pluses or smiles or stickers, then you come home and you had a good day.
You get rewarded.
Now we can cash in our points from the morning. Right after school, what do you want to do? You've got 15 minutes to spend these points. It can be, we can play a game together, we can work on a puzzle together, we can watch half of a show together, pause it for later, we can go shoot hoops in the driveway together, whatever the case may be. You can go read a book alone, and 15 minutes may not be long enough. We may need to make it a 20-minute block. It just depends on your child. But the point is, you reward with incentives, some kind of token or point system. You cash those in, and that keeps the motivation going. That keeps the positives flowing, where there otherwise would be a lot of, I think, arguing and negatives going on. So at home, same thing. You've got this structure. You've got this incentive program, charts, responsibility boards, and you're rewarding your child every chance you can get. You're following that 8-step behavior plan, and I'll just talk to one point on that plan. When parents come in and their child, they're in a lot of friction with their kiddo, and they're frustrated, they cannot get this child to do what they want him or her to do. The child's frustrated with the parent, they think the parent's nagging them, they're always yelling at them. So it's interesting to hear both sides of the coin. And what I've learned is that you have to start something positive and very concrete. So step 1 in the behavior modification plan is powerful, positive attention to your child. And when I say that, I say to the parent, this is 15 to 20 minutes of powerful, positive attention to your child, one-on-one, every day. Now, if you can do 20 to 30 minutes, hallelujah, I think that's better. But sometimes families are really scattered and busy, and I say minimum of 15 minutes, preferably 20. And what this looks like is the parent assigning it on their calendar after work, after school, to catch their child engaged in something the child actually enjoys doing, and to go alongside and join the child. Ask for permission. Oh, can I build blocks with you? Oh, you're coloring. Can I sit with you while you color? And if the kid says, yeah, I don't care, you sit down and you start to just give powerful, positive attention to the child. You don't ask annoying questions. Kids hate that. How was your day? Fine. No kid answers that very well. They don't like that question. They feel nagged by a lot of the typical things parents say or do. So in this 15, 20, 30-minute block of time, you're only looking at this child with amazement, with love. Your eyes are full of love when you make eye contact. You might even be thinking, I love you, while you're making eye contact with the child. You don't have to say it. You're just maybe thinking it. If it's appropriate to say it, if it's genuine and in the moment, say it. If your child isn't resistant to touch, it's good to put your hand on a shoulder in a warm way. If your child doesn't like being touched, that's not good to do, so you need to know your kiddo. But you can just narrate what you see them doing. You don't ask questions that could be perceived as annoying, but you can say, wow, you're really using a lot of nice color on that picture you're drawing, or man, look how big that tower is you're building. That's awesome. I like playing with you. You're really relaxed right now, and it's fun to sit here and just be with you. Things like that. So speaking the truth, narrating what you see, not putting any statements of judgment on what you see them doing, and not asking them any questions that could stress them out. Okay? That probably covers some important points. There's probably a lot more we could say about that, but that's what I would say. And as far as giving a command, like if you need to get a response from the child, important to remember, you do want that eye contact. You do want to make sure you have their attention and that they're not occupied with some toy or other distraction. So entering into their space very calmly, again, making eye contact. Hey, we have to leave in 5 minutes, so I need you to go put your shoes on right now, okay? And depending on the response you get, if you get pushback or resistance, then you'll go to one of the other steps in the behavior modification plan. But I think the point you were wanting to be made is make sure you're not rushing around the house yourself, mom or dad, cleaning the kitchen as you go, and then saying to Timmy, hey, you need to get your shoes on, it's time to go, and thinking that child actually heard you and is going to respond to you because they didn't hear you, or it certainly didn't penetrate them in a way that you're going to get compliance. So you do need to make sure you issue a very clear command when it's time for them to obey you. And if they don't take action within the time you've given them, then you need to follow up with, here's the consequence if you don't do that, here's the incentive or reward if you do. Now you're hearing me use the word incentive, reward a lot, and if you're not familiar with this disorder, you might be thinking, oh, you're bribing the kid, and in reality you're not, because this is a child whose brain is not able to hold on in working memory to what it is they're asked to do. It is not able to self-direct over time, meaning being able to manage time the way that a neurotypical child can. It's a child who doesn't have internal drive and motivation. That part of the brain is not firing. So when you look at the CT scan of that brain, if we have a neurotypical child and an ADHD child doing the same worksheet, you will see light up in various regions of the brain for the non-ADHD child who is accessing all of those skills to pay attention, to stick to the task, the internal drive and motivation. All those areas of the brain are actually lighting up the way that they should in order to complete the task. When you look at the ADHD child, there is virtually, there's so little light up in some areas of the brain, it's almost, you almost have a tearful reaction, like, how is this kid doing as well as he is doing? When you see that, the discrepancy there. So I would want parents to remember that this sluggishness, this resistance, even the argumentativeness, that's all brain-based. There's a reason that they're doing that, and it's not to give you a bad day or to intentionally be a difficult child. That's not their intention. In fact, I think it's their curse that they have to walk through the world with these extra challenges and learn how to get along in the world with all of this extra garbage going on for them. Okay. Got any other questions?
I think we're at 30 minutes.
Are we? Okay, well, let's pause for a minute. Okay, so we're going to pick back up. Just to summarize, we talked a little bit about collaboration with school. If you are a clinician helping a family with an ADHD client, child, you're going to want to help that family collaborate with school. You may even want to get involved yourself. I've done a lot of IEP meetings and phone calls to schools and meetings at schools to help facilitate the right accommodations and to kind of help bridge what's going on at school and at home and what we need to address with the parents in therapy. Which brings me to another point. Because this isn't a knowledge or a skills disorder, this is a performance disorder for the child. The therapy isn't so much, for the kid as it is for the mom and dad, for the parents or the caregivers, because what we want to focus on is what behavioral modification plans need to be in place for this child to show what they know and to be successful, whether that's doing chores or tasks or homework or school assignments or social interactions. So we have to re-engineer the environment because this is a brain-based disorder. This is not, I keep saying it, but I want to make sure it's understood. This is not willful behavior when this child is not doing what you think he or she ought to be doing at school or at home or on the ball field or wherever they are. It is rooted in what's going wrong with brain development. So we have to re-engineer the environment. One of my favorite Barkley quotes, he was actually talking about a time where he was working with some teachers about how to accommodate one of his clients. And he said teachers always wanted to know, how long do we need to do these behavioral interventions? At what point can we start to wean the child off those interventions? And he said, the best analogy I can give to help them understand it is, say you have a child with mobility issues, a child that's confined to a wheelchair who can't walk. You would put a ramp going into the building so that the child could successfully enter the building. And he said, going with their questions about how long do we have to do this, you wouldn't say to that child or that family, upon 30 times of successfully entering the building, we will remove the ramp. He said you will always need to sprinkle on these external motivators. You will always need to change the environment. You have to engineer the environment at the point of performance, wherever it is out there in life, where you expect this child to do whatever it is that's expected of him or her. That environment will always need to be altered, accommodated, engineered in a way for that person to show you what they know. Remember, it's not that the knowledge is here. The brain, the back part of the brain learns and stores knowledge. The front part of the brain allows you to access that knowledge and show it, perform it. And ADHD has separated those two parts. He says like a meat cleaver. It's just cut them in half. So the person with ADHD doesn't have nearly the same ability to access what they know. So you absolutely have to change the environment for them to show us what they know. So we've talked about collaborating at school. We've talked about behavior modification in both environments. We've talked about that it's a complex neurobiological disorder of self-regulation. It's not just a problem with paying attention or being spacey, daydreamy, fidgety, but impulsive. That dysregulation, that emotional part, makes this child very impulsive. Verbally, they're going to say things that they shouldn't have. And as adults even, I have adult clients that say, oh, why did I say that? They say it, then they think after the consequence, and you can't take it back. So this is a person who's going to be much more verbally impulsive. And for little kids, usually toddlers, early elementary age school kids, they're also sometimes physically impulsive, whether that's climbing on things or putting their hands on people or things that they shouldn't. And then sometimes with that irritability that goes with this disorder, being irritable, quick to anger, quicker to frustration, and more emotionally intense and raw when they are angry, that can sometimes lead to hitting behaviors and aggressive behavior. And that's absolutely going to cost them friendships. So one of the things that is a hallmark characteristic of this disorder as well is that these are kids who, by the time second or third grade rolls around, they're not invited to the birthday parties. They're not invited to the play dates at their friends' houses like other kids are. And this is a child who oftentimes has no friends or has just one or two friends. So we have to work on engineering the environment in a way to help them with that as well. You know, I think one thing that strikes some parents as funny at first is when you tell them you need to engineer your home environment in a way that makes other kids want to come play at your house. So you want to have the cool video games, you want to have great snacks at your house, you want to have a home environment that's fun for other kids to want to come play at your house, whether your son or daughter is there or not. The kids, you know, maybe they'll come and play because your house is fun and you're fun, and it's a feels good place to be. So you want to help parents with that. Sometimes parents shrink back because they've had a bad experience or two with kids in the neighborhood, or their child behaves in a way that's unpredictable, and they tend to pull back and isolate a little bit, and the cost of that is not good. So we want to help families with that, and that's another reason to be in treatment. So again, we're not teaching kids social skills in treatment because they're not going to stick. This is not a knowledge disorder. This is a disorder of doing what I know I'm supposed to do. So teaching kids social skills in therapy isn't going to be helpful. Doing cognitive behavioral therapy for children isn't helpful with ADHD. Now, it can be helpful for them to have a place to de-stress if they're getting a lot of friction in the world because of the way they're interacting with the world, to be able to come in and talk to their therapist about how angry they are, or how unfair so-and-so was, or what happened at school this week. That is helpful, and I think it keeps them clear. So I think that is a good reason to do therapy with the child. But the bulk of the therapy that I do is with mom and dad,
parents,
helping the parents, and also giving the parents a place to de-stress. This is a very tough job. If you are a parent or you work with parents who have a child or children with ADHD, it is an incredibly stressful role to be in. And there's a lot of science to back that up. There was one study that I read that said that parents of a child with ADHD are under the amount of stress as parents who are parenting a child with mental retardation or a serious physical disability. So you want to, if you're a clinician or an educator, you want to be mindful of that. So sometimes when you start interacting with a parent, you're going to get a parent who's pretty frayed emotionally, and you want to help with that. I think first things first, you want to help the parent kind of get grounded, recentered, give them some validation and affirmation that this is a very hard job. It's exhausting. It's 24/7. You are 24/7 navigating the environments for your child. You are your child's frontal lobe. You know, all of the things that the frontal lobe does for us helps us stop and think, filter out unimportant information that's distracting us from our goal, helping us manage time, helping us plan ahead. That frontal lobe of this child is not working very well. So as the parent, you're helping your child navigate all of that, plus you're probably getting a certain amount of obnoxious, rude, emotionally raw, intense behavior directed at you because you're their safe person. So you're dealing with a lot, and then you're dealing with the general public who does not understand this disorder. They ought to. It's been around forever. Treatments have been around forever, but there's still
a lot of myths out there.
A lot of myths. So I would say help parents understand and have a safe place to feel and heal and forgive and keep going at it, because it's a marathon. It's not a sprint.
And you talked about parental involvement, and especially treating or educating or bringing the parent alongside you in your knowledge. And it's not just the responsibility of a parent. It really needs to be a collaborative parental environment at home too. So it's not just mom, it's
Right.
mom and dad,
Right.
and then really the entire family, if you can get it to that point.
Right, so doing some family therapy,
Mhm.
so siblings understand what's
Mhm.
going wrong. And I mean, yeah, ideally there is two parents, whether it's mom and mom, dad and dad, mom and dad. Sometimes there's not, you know, there's, as we all know, there's a good number of single parent households. And, you know, to your point about siblings and even extended family, helping extended family and siblings understand to the best of their ability what's going on, because what we do see is a lot of sibling rivalry, a lot of conflict in the sibling relationship. And siblings who have a brother or sister with ADHD are oftentimes angry and resentful that, you know, hey, how come he doesn't have to do this or that, or why isn't he in trouble, or, you know, you hear these things
Mhm.
in the therapy room, and it's, you know, they need to understand that their brother or sister's brain is developing more slowly. There's some delays there. There are some brain-based limitations, and it's not willful, you know, bad behavior that's causing the family to have this meltdown or this tantrum or this cognitive inflexibility that's making you late. But we also need to make sure we're accommodating for those kids that are neurotypical. We don't want them late for school. We don't want them having to deal with so much extra stress. So it does become complicated, and that's really an individual family by family basis that I would answer those questions. You know, what's going on in your family system? And then whatever that issue is, we problem solve around it. You know, what are some things we can do to bring in extra help? Maybe, you know, this is sometimes hard for families to hear, but sometimes if we've got two working parents and mornings are chaos, my recommendation is there any possibility in your schedule, in your life, in your workplace, for one of you to go to work an hour later, or to work a 6-hour day instead of an 8-hour day?
Mhm.
Can one of you go in at 9 a.m. instead of 8 a.m.? And can one of you be home by 3 p.m.? So you're home a half an hour before chaos. And the other parent, you know, maybe, so you stagger that in a way so that you have a grounded, mentally geared up parent for whatever the task at hand is going to be, because it's going to require more effort, more energy, more peace and calm, more structure, and we want to help parents figure that out and problem solve that out. So does that hit on your, okay,
Mhm.
all right.
Yeah, it's back to the,
Mhm.
it takes a village.
Yeah, it
of
does.
it.
And grandpa and grandma and
Mhm.
aunts and uncles, because these are folks that are sometimes going to harshly judge your child for that outburst they saw at
Right.
Christmas time. And you want them to understand
The
what's
sooner.
going on neurologically with that child, why that happened, and help them with knowing what you're doing, why you're doing it, and if they happen to be there alone with the child, what they can do to help that situation and not hinder it. Because the wrong adult intervention can really blow up that bad behavior and make it much, much worse. So we want to help adults in the life of the child understand, here's what's happening, here's why it's happening. Because without understanding the why, people lack the compassion they need to really have a relationship with the child and to help the child. And I think that is so hurtful to see when you're a parent and you have this child with ADHD and you see adults being harsh or critical or judgmental or just awful for, you know, long story short, just whatever it is that they do that is trying to control the child and fix them. It doesn't work because it's not rooted in willful behavior or a moral failure. It's rooted in brain-based developmental delay. So when we have adults that don't know that, they intervene in ways and they make it worse. And of course that child not only then gets triggered by that inappropriate interaction, they also feel guilty, or what's wrong with me? It hurts their self-esteem because they don't know why they can't do what you want them to do. They're small children especially. They may learn fairly early on, there's something different about me. I don't seem to be able to do what my peers are doing on time, but they don't know why. And so they're, of course, going to interpret that as there's something weird, dumb, bad, or different about me. And the knee jerk will be, I don't like me. And that's what we want to avoid at all costs. We don't want to see that happening. So I would tell parents and clinicians and educators that to do everything you can with the people that are going to be in close proximity to your child to help them understand what's going on so they don't make those mistakes.
Right. So you've talked about school, home, treatment.
Let's talk more about treatment. I don't know
Okay.
that we've done enough of that.
All right.
I know I mentioned early on in the video, I think, that we used to try everything else first before we talk about medication, and what we've learned is medication is the most effective treatment we have.
Mm-hmm.
This is a neurogenetic disorder, and it requires a neurogenetic treatment. And 80 to 90% of patients with ADHD are helped most significantly by the medication. So we don't want to delay that. We want to add that on as soon as we know for sure this is the diagnosis, and we go ahead and move toward medication so we can help level the playing field for this child. Otherwise, you've got a child at school with 90% of the class, 93% of the class neurotypical, and you've got this ADHD child who can't manage time as well, can't foresee the future as well, can't plan as well, can't organize as well, can't use working memory as well to hold things in mind so that they can do what they're supposed to be doing, can't regulate their emotions as well, and we expect them to get along in the classroom and feel okay about themselves and feel successful.
Because they
It's
look
not
like
gonna
everybody
happen.
else,
Right.
but they're not.
And they have other gifts,
Right.
these are the limitations or the disability pieces, but what do we have, 400 genetic traits, each of us? ADHD is just a small set of them, but you can see how it's pervasive and it affects them in every area of life. But in addition to those deficits, they're going to have their gifted parts. Maybe he's a great artist or a great dancer or a great athlete or a great musician, or in the case of my son, an avid reader, and he's, he eats books, and he's got a great vocabulary because of that. And that can come off as, wow, he's so smart, he's got this great expansive vocabulary. Surely he could do X, Y, Z in the classroom if he really wanted to. Mm-hmm. And if you don't understand the disability, you'll make that wrong judgment. So treatment, medication, let's get that on board as quickly as possible if we have ADHD. These medications have been tested for many, many decades now. They pose no risks or harm. They are non-addictive unless obviously you abuse them when you get older. There are kids who've now learned to snort or abuse those medications. So they can be abused if they're not treated, if they're not taken as prescribed. But for your child with ADHD, taken as prescribed, there's no risk of abusing the drug, of addiction. And some of the myths out there about, kids who are overtreated, they're not overtreated. We know that 7% of the population has this disorder, and we know that only 5% are under treatment, medication treatment. So we're not over-medicating our children. Now, does that mean that there aren't some cases out there where there's a doctor who is not in the norm group, who's maybe over prescribing or prescribing the wrong thing for the wrong disorder? Of course, there's going to be human error, but for any conscientious parent, educator, clinician, you're not going to let that happen. If your child has the disorder and needs the treatment, you're going to want to work closely and collaborate with that pediatric psychiatrist. I would recommend a specialist, somebody who specializes in these medications, and communicate back and forth until you get the right med, the right dose that's going to help your child's symptoms get reduced down as much as possible so that they're able to succeed. And under treatment, that 30% delay, emotional delay, that goes away. So while this child is on their medicine, maybe between 7 a.m. and 3 p.m., and that 30% delay, really that gap closes, and that child performs much more within the norm of his or her peers in the classroom. Leaving medication out of it, what we've found is they're not as able to utilize the executive functions in the brain, and that causes them to have a lot of school failure, school trouble, social trouble. So I would say put that on first off. I would also say make sure this child is engaged in intense aerobic activity, at least 30 minutes a day. So find an activity your kid likes, or make it a family event. If it took us a while with Jack to find something that, and we had to shift a lot of different things around, but whether that's running, soccer, basketball, swimming, karate, rock climbing, I've seen all these things done in families, and they work when the child decides they're into it. Once that happens, you're off and running. But until that happens, you might need to do family hikes, family bike rides, family let's go to the track and run around the track, and whoever can finish the most laps before we go gets a 2-scoop ice cream and the rest of us only get 1 scoop. You do stuff to try to make it fun. And being outdoors, green space has been shown to be effective for treatment with ADHD. Let's see, there's neurofeedback, things like that. You've seen commercials like Brain Balance and all that. I've seen mixed reviews on that, and I would be skeptical of anything that's excessively expensive and promises the moon and the stars. This is a disorder that there is no known cure for. So when you see a commercial that says now he's cured, that just isn't so. Like diabetes, we manage ADHD. And for most people with it, it's a lifelong course of management.
Now, the management too, that part, it's not all right, you figured out here's the right treatment or medication A, and that's what your child is going to be on for the rest of their life.
Right.
Talk about that
shifts,
too.
Yeah. As they develop, their needs change, so sometimes medications need to be changed. Sometimes interventions, the behavior modification plan. So yes, that's probably one of the hardest parts, I think. When you're new to this, a parent who just got their child's diagnosis and the kiddo's 6 or 7 years old, and you go through this intense learning curve. It's usually a very stressful first year of getting this diagnosis. We've got to learn everything we need to know about it. We need to understand the medications. We need to find a physical activity if we've had a child who's more of a couch potato kiddo, which is oftentimes the case. They like video games or things that are instantly gratifying and rewarding, because their brain really does thrive on that. So we have to change the structure at home, the environment at school. We have to learn about treatments. We're on this huge learning curve that first year. And then we get it. We get the med working, school's working, home's working, and we're like, yeah, we've got it. And then the kid changes. we go into a new developmental stage, and all of a sudden we're learning all new things again. Right. And this can be as simple as, we've gotten bigger and the medicine doesn't work the same. It can also be that there are new social expectations out there. Now we have a child who needs to start using deodorant or shaving her legs or whatever. And so we have new expectations at home for the child to be socially accepted. And, I've seen parents really fret over these kinds of hygiene issues and various other issues. So we just kind of take it one day at a time, and I think after the second round of major learning curve, usually parents get it. It's like, okay, my child is going to keep on developing, and it's always going to be a little bit delayed, and maybe what would take another child one good conversation and a reminder here and there, and now they know I put deodorant on every morning. This child might need a 3-month period of time to get to that place, but they will get there. And I think that's the thing I always try to remind parents that are fretting about that. They will get there.
Okay. All right. We've got a little bit more time for this section, and trying to think of something that hasn't been covered.
Let's talk about untreated outcomes, right?
Oh, okay.
Because a lot of times, and this is always sad to me when I get a teenager client that comes in who's suffering from school failure. Yeah, like I'm thinking of one kiddo in particular that I treated for a couple of years, a few years back, and he had all D's in school. He was in a good school. I'm not even going to say public or private. I don't want to give any information away, but good school, but he was doing miserably. But he was smart and he was articulate and he presented well in therapy. Parents were really frustrated, did not seem to understand his ADHD. He had never been on medicine for ADHD, had no accommodations at school, and he was a freshman in high school with straight D's. And they brought him in because he was also being rude, disrespectful at home, arguing, they were just exasperated. And as I got to know him over a session or two, I learned that he had been diagnosed when he was 6 in first grade. They had known about it. Long story short, they said that they didn't realize it was really a big deal. They didn't realize it was a serious disorder. They had heard from, I think it was grandma, that this is just something schools are doing now to try to get kids to sit still, and the medications are bad, and their kids are over medicated. So parents decided they didn't really need to do anything, even though they had a educational psych eval from a good doctor, one that I'm very familiar with, that had recommendations in it and a lot of good helpful information. I guess they had never really reviewed it closely. They had never shared it with school. And therefore, this was a child at 15 years old who had never had any help or treatment or knowledge about his ADHD at all. And I guess the defense system I would say he had was sort of this cocky, edgy exterior, definitely trying to hide his low self-esteem, like he was fine, he knows he's smart, he just isn't doing what he's supposed to do. But so he didn't understand it, they didn't understand it. Here he is now suffering from school failure, and now we think he's also smoking pot and drinking, and he's being awful at home. Can you please help us? So that is not what you want to find in your clinical work. You much rather catch these kids when they're 6 or 7 years old than when they're 15 years old in this boat. So they got the talk that I would give any parent, what I would hope to say to them when their child is very young. This is a serious, complex, pervasive disorder. Medication is our front line, our best defense of it. It's the best way we know to manage it. So we have to medicate. We now have to do some self-esteem work because this kiddo's having some low self-esteem and relationship issues, communication problems. So we have to work on those things. Now we do have some skills to talk about. And we have a lot of parent coaching to do. So when I saw that kiddo, I thought about these untreated outcomes. And here's what happens. If you choose not to treat your kid with ADHD, or if you have parents who are saying, I'm not going to do this treatment, we know that diet doesn't work. It's been studied. We know that supplements don't give you a significant improvement. It's been studied. We know that behavior management alone isn't going to close the gaps. So we have to talk about medicine, even though families are reticent to do that. A child who isn't treated, they're going to be at a 30% greater risk of being retained at least one grade in school. They're going to be at a 32% greater risk of dropping out of high school before they even finish high school. And in this day and age, that seems crazy to me, that you would let your child get into that risk group where they're not going to finish high school, or they're going to fail or be held back a grade. They're 50% more likely to be in strained relationships with their peers, and to also have difficulties with dating relationships and that kind of thing. Their sibling relationships, we talked about that earlier, they're going to be strained. This is a child who is 7 times more likely to be abused. So an untreated child with ADHD is 7 times more likely to be abused. And that's not just by the family system, that can be by coaches, teachers, people out in the world. They're at a greater risk for substance abuse, drugs and alcohol. Their brain is definitely more susceptible to addiction, so you want to be very mindful of that. They're also going to be more promiscuous. Why? Because they're more impulsive. So they have a 32% higher rate of teen pregnancy. That's big. That's life-altering. And then serious car crashes, more damage to self and the vehicle. So these are reasons why you would want to treat. I'm going to wrap up from here because I know I've been going on for quite a while. You can reach me at schedgecock@gmail.com if you'd like more information. or you'd just like to talk some more about any of these issues or any other ADHD related issue. Thank you.